Welcome back, everybody. Thanks for tuning in for another episode of Urgent Care Stories. Today is going to be an orthopedic episode. I used to work in orthopedic surgery. I did a lot of hip and knee replacements, revision arthroplasty, trauma, hospital and ER consults, that sort of stuff. So I've seen a lot of ortho stuff, and I've done a lot of ortho cases. So ortho is something that really helps you when you get into the urgent care world. Today's case is a woman who is in her 40s. And the history goes something like this. She doesn't have any chronic medical problems. She's relatively healthy, doesn't take any medications. For the last 6 months, she's been having these intermittent episodes of severe pain and swelling to her right knee. The episodes will kick on all of a sudden without any specific injury, no changes in diet, no activity changes. And the knee gets really painful, really swollen, and she's been to the ER for it a couple of times. They do x-rays, tell her they're normal. They never drain the knee. They just give her narcotic pain medication and send her on her way. This is a type of patient who doesn't have a primary care doctor either. So a lot of times they're not getting the follow-up that they would really need to get down to the correct diagnosis. So she comes into my urgent care because she's having the same complaint that happened about 3 days ago. Pain and swelling to the right knee. It hurts to move, hurts to bend, hurts to walk. There is no history of recent trauma or injury, okay? So what's our exam look like? Well, on examination, you look at the right knee and there's a large amount of fluid, what we call an effusion in the right knee. There's no warmth to the knee. There's no scabs, no skin breakdown, doesn't appear red or inflamed. It's not warm. And so it doesn't look like an infectious cause, and it's all swelling right around the knee joint and the capsule of the knee itself. So what am I thinking when this comes in? Well, without a history of a trauma or injury, you're thinking of other reasons why you could have a knee effusion. Gout and pseudo-gout are definitely causes that can cause this. Some sort of an infectious etiology. So if she has septic arthritis, that's another cause. Could she have arthritis to the knee, degenerative arthritis, rheumatoid arthritis, something of that degree that can cause these inflammatory processes, stuff like that. Those are my initial considerations. Infection, typically you're going to have warmth within the joint itself. It's going to be red and inflamed. They might have a history of fevers, they might not. Usually you're going to either have a spread nearby, so they have a scrape, a scratch, a wound, a nearby abscess, something that's kind of a local area for the infection to get in. Sometimes they can just have hematogenous spread, so it's an infection somewhere else in the body, and it ends up seeding itself through the bloodstream into that knee. The way that we would officially confirm that is we'd tap the knee, we'd draw fluid out, we'd send that out for a culture and sensitivity and cell count. If we see greater than 50,000 colony forming units, enough bacteria, or if there's any growth, or if we have an elevated ESR or C-reactive protein, those are all markers that can suggest that this is a septic arthritis condition. The other thing is gout. So gout is a condition where the kidneys don't filter through uric acid properly. It's a defect in the URAT1 gene, and basically they just hold on to uric acid a lot more than your average person will. Typically the story is going to go, they usually have a history of gout in the past or a family history of it, and they're usually going to have something in their diet that has been different lately. So the big ones are the cheese, beer, organ meats, seafood, a lot of protein sources, like they had a big steak over the weekend, or they were at an all-you-can-eat buffet with a lot of shrimp. Anything that's high in purines has a lot of uric acid in it, and what happens is the kidneys just can't filter out all that uric acid, so you get this inflammatory response, and all this uric acid accumulates in a joint space. Most commonly it's going to be the toes, ankles, knees, sometimes the elbows, but that's one condition. You're typically going to hear that history though, and this woman has never had a history of gout. She had no change with diet at all. So less likely that this is gout, but how do we confirm gout? We'd tap the knee, we'd send it out, and we'd get crystal analysis. We'd be looking for what's called a negatively bifringent crystal, which is the uric acid crystal, and if that's found, then that confirms your diagnosis. The last condition is called pseudo-gout. Pseudo-gout meaning similar to gout, but it's a pseudo-gout. It's not the true gout crystals that are uric acid crystals. These are positively bifringent calcium oxalate crystals. Now, this is a genetic condition. Some people just have more predisposition to it than others, and you'll get these flare-ups. And to my knowledge, I don't think there's any specific cause to them. I don't think there's a lot of diet changes. Sometimes if they have high calcium intake, or if they're on like a bisphosphate or something that makes them retain calcium, sometimes that can theoretically cause this. But it's a calcium oxalate crystal, and it just inflames the knee and produces this calcium buildup. What you're going to see on the x-ray when somebody has pseudo-gout is you're going to see chondrocalcinosis. So you're going to see a hardening or a calcification of the cartilage, usually around the meniscus. So let me go ahead and show you guys what her x-rays looked like. I'll pop them up right here. This is just looking at an AP view of her knee. What you can see is she's got fairly decent joint space in between the tibia and femur on both sides. So we don't see a lot of arthritis. We don't see a ton of bone spurs. Obviously, we don't see any fractures. And given that this history has been going on for more than 2 weeks, if this was a septic issue, we would have seen findings of osteomyelitis, which would have been kind of a bone infection. And we don't see that with this x-ray. What we do see is that chondrocalcinosis, calcification of the cartilage. In this case, we see those 2 white lines on either side of the medial and lateral compartment, and that's calcification of her meniscus. That right there helps me confirm her diagnosis. Fits with the history, fits with the story that there's no change in diet, and the x-rays confirm this is pseudo-gout. The official diagnosis of pseudo-gout, you're going to tap the knee, you're going to send it out for crystal analysis, and it's going to show these positively bipharyngent calcium oxalate crystals. What do we do for this person? Well, if it's an infection, if it's gout, or if it's pseudo-gout, it's worth tapping the knee. Now, how do we do a tap? Well, my favorite way is a lateral parapatellar approach. So what I do is I straighten the leg out on a bed, and I put a little bit of a pillow underneath the ankle to try to get the knee as hyperextended as possible. You should be able to feel kind of a fluid wave or kind of a pocket of fluid within the knee. Now, the knee joint itself has a lot of ligaments and a capsule that encapsulates the knee. So all this fluid, the synovial fluid, stays within that capsule itself. The only time it wouldn't is if there's a rupture, like a Baker's cyst that ruptures and it streaks down the leg. But in this case, we feel that there's this large pocket of fluid. What I do is I feel the top of the patella, and I go laterally, and then I come about a finger breadth or so up and laterally from the superior pole of the patella. That's your entrance point right there. Now, what I recommend is I get an 18 gauge needle with a big syringe. I'm talking at least 20 cc's. If I can find something bigger, I will. This is going to be dependent on how much fluid you think the knee has in it. This lady had a large amount of fluid in her knee, so I grabbed a couple of syringes. I think I had a 20 and a 50 cc syringe. You clean off the area, you try to make this as sterile as possible, betadine, chlorhexidine, alcohol, whatever you want to use for your cleaning solution. Sometimes you can give a little local anesthetic right through the skin in that area, but to be honest with you, it really isn't going to change the pain experience for the patient because you're sticking an 18 gauge needle in through their muscle, down, you're going to be hitting a little bit of bone, you're going to be inside the knee joint. So it's hard to make that completely pain-free for people. So sometimes, this case, the woman was in a lot of pain, and so I ended up trying to give her a little lidocaine just to give some relief for this. So I mark my areas, I clean it off, I give some lidocaine, wait a few minutes, and then I take my needle, stick it straight in, try to go parallel to the plane that you're on, and you should feel a pop that you're going through the capsule. Now, the way that you can confirm is you're going to get a flash of fluid through the line, similar to when you start a IV or when you're drawing blood, and you just want to pull back. You want to aspirate a little bit, and if you get a pocket of fluid, then you know you're in the capsule, and you just start pulling. Sometimes when you get in, you might have to re-angle and kind of change position, and in this case, it took me probably 2 or 3 positions to try to find the capsule. Sometimes you poke in, you might be just above, just below, might be a little bit tricky to find, but in this case we were able to get it. So we tapped the knee and we drew out fluid. The synovial fluid usually is going to be kind of a clear to yellow color. If there's an infection, you're typically going to see stringing or more purulent looking material, stuff like that. If it's a traumatic effusion, you're going to see a lot more blood. In this case, it was a pretty clear looking fluid. It did not look infectious to me. We ended up pulling all that fluid out of the knee. I I think I took out about 100 mLs, 100 cc's of fluid from this woman's knee. You start to milk the medial knee, pushing all that fluid into your area, and you just keep drawing fluid back. You can grab multiple syringes, just unscrew the needle, screw a new syringe on, and keep aspirating. Or in some cases, you can have an assistant who will, empty the synovial fluid, for you, and then hand the needle back to you, and you can keep going from there. Once you finally got all that fluid out of the knee, the treatment for pseudogout is a corticosteroid injection into the knee. So what do? We have the needle already in the capsule of the knee. We've pulled out all the remaining fluid. Now I inject with steroid. The steroid is just going to be of your choice. I use betamethasone because that's what I have in clinic here. Depomedrol is good, Kenalog is good. It really just depends on what you have available to you, but there's different dosing per steroid, so just find what works and you can look that information up. We did a little bit of Marcaine to anesthetize the knee, and then we did the steroid as well. I wrapped the knee in an ACE wrap to give some compression to try to prevent it from swelling for her. And then we also gave her an injection of Toradol for the pain as well. The response from this should be pretty quickly. What you should notice is that within about a day or two, the steroid should reduce the production of the synovial fluid, helps with the pain, calms down the response. This woman did phenomenal. Within about 48 hours, she was back up, doing great, had no problems with the knee. Everything was feeling really well. She had a great outcome. I elected to not send out crystals in this patient. I just didn't want to give that added cost when I was confident in my diagnosis. Didn't see any signs of an infection, had x-ray findings that shows my pseudogout diagnosis. So to me, I was confident enough with that. But again, clinically, that was my choice. The correct answer would be to send out for crystal analysis. It is just more cost to send out lab testing for cultures and crystals and all that sort of stuff. If I'm ever unsure, or if I don't see those x-ray findings, I am going to be sending the rest of that stuff out to confirm. That was how to tap a knee. That was pseudogout and kind of the thought process through somebody who comes in with a complaint like that, guys. You're gonna see it a lot. Knees are the most common joints that I see with pseudogout, but it can happen other joints. You're just gonna be looking for that chondrocalcinosis, or you're gonna be doing the crystal analysis to help confirm that for you guys. Hope you enjoyed this episode. Hope you learned something, and we'll see you on the next one.